Okay, our next speaker, just like Dr. Blake has a plethora of academic accomplishments, Dr. Azzolino is an internationally renowned clinician who's been serving his profession and patients from around the world since 1995. May 24th, he was appointed by Governor Edmund Brown Jr. to the California State Board of Chiropractic Examiners. January 2014, elected chairman of the board, continues to serve as chairman of the scope and practice and enforcement committees. Dr. Azzolino has blended his background in nutrition and sports medicine with years of advanced postdoctorate training in functional medicine, neuroimmunological studies to provide a comprehensive, unique approach to his patients' care. Dr. Azzolino will discuss brain-based rehabilitative strategies to maximize brain function in health and disease. He has achieved international success with the brain rehabilitation programs for the treatment of traumatic brain injuries, balance and movement disorders, and a variety of chronic diseases such as Parkinson's disease. He has also worked with numerous professional athletes and individuals striving to maximize their performance. Please help me welcome Dr. Azzolino.
How's that? Okay, thank you. Big thank you to Dr. Blake. That was spectacular.
Thank you.
Very refreshing and very well referenced, I must say. I heard I had half an hour, so I saved most of the references. I'm happy to discuss them with you. I'll make myself available after if you have any questions. I'm a clinician. I love dealing with patients. Many of the changes that we see on a daily basis, and they're verified with objective testing. So we're going to move right through some specific things that all of you can be doing for a variety of things, including and especially Parkinson's disease. I run a multidisciplinary clinic. We have a naturopath. We have a medical physician there. We do the gamut from rehabilitation to IV nutrients to hyperbaric oxygen, and we all take a look at our patients from a variety of different perspectives and truly believe, especially with Parkinson's disease, that we need to take a multifactorial approach. We must rule out infections. Unfortunately, all too often in this day and age, I know there's some great physicians in the room, but when a patient gets labeled with Parkinson's, oftentimes the examination stops and people just start treating the condition, not the patient. Quite often we see infections from Lyme disease to a variety of different types of infections mimicking neurodegenerative disorders. Those need to be addressed. We see toxic elements, toxic factors. We see a lot of mycotoxin illness. We see a lot of heavy metal toxicity. Someone asked about the zeolites. Love the idea. Looked at them for many, many years. Haven't seen any good post-testing with our patients on, after doing DMSA challenges and whatnot, and a reduction of levels. And we deal with metabolic aspects. Certainly in the management of Parkinson's, most people in the moderate to advanced stages are using some pharmaceutical intervention. IV nutrients can be extremely beneficial. IV glutathione is something that, many of you probably have seen Dr. Perlmutter's videos and things of that nature, phosphatidylcholine sometimes. Simple explanation we say to our patients is eating right is absolutely the most important thing to do. Agree 100%. I'm not plant-based, admittedly, but eating right is the most important thing to do, but sometimes we can't replenish the tank quickly enough when the clock's working against us. So we also have seen significant reduction in the speed of the progression of the illness or improvement in clinical outcomes utilizing hyperbaric oxygen. And most importantly, what we're going to talk about tonight is the rehabilitative measures. So, famous picture here. We're going to move right through these things. If anybody has any specific questions with Parkinson's, please ask, but otherwise I'd like to get right to what we can be doing clinically. So when we look at someone from a functional neurologic perspective, what we need to be looking at is measuring their function. The UPDRS is a great scale. great scale to look at, but we could look far beyond that. We want to identify where their specific weaknesses are, because once again, no two Parkinson's patients present alike. As many of you know, one person may have a tremor starting on one side. They may have significant rigidity on one side of their body. They may have significant changes in speech or handwriting. All of these are specific to various parts of the brain. Yes, the substantia nigra is the culprit. However, that's point A for many things. There are many other aspects of the brain, and so we need to look at the integration of various aspects of the brain so that we can very specifically formulate a customized treatment program to address that individual. So very specifically, what we want to do is identify their area of weakness and apply therapeutic strategies that are going to be very specific to optimize that individual's function. Before we engage in any rehab program, we have to keep in mind that there are three things that all nerves need to survive. Number one is oxygen. We can't go more than a couple seconds without it. We need fuel delivery and nutrient delivery. And we need to activate the receptors. Receptors are peripheral nerve endings in our eyes, our ears, our joints and muscles. We are creatures that will not survive without receptor input. Ways that you can maximize your oxygen intake on your own is quite simply, most of you know, breathing exercises, ruling out anemia, ruling out metabolic disturbances. You know, it's alarming how we see so many people with Parkinson's disease have diabetes and have these other aspects, and they're not being addressed because they have Parkinson's disease. Well, on from there, with many other metabolic disturbances, certainly high levels of iron, as Dr. Blake suggested, is terrible for the basal ganglia. Men that are non-menstruating men, as most of us are, should not be taking iron in our supplements. Things that you could also do is just address your simple rib mechanics. One reason why exercise is so beneficial is by simply causing forceful exhalation and inhalation. So you could blow up balloons as an exercise. You could do deep breathing exercises, take singing classes. All of these things are good for the soul and good for your rib mechanics. Certainly, you could have your chest wall manipulated by people from chiropractors to osteopaths that know how to deal with this appropriately. And hyperbaric oxygen, once again, is, it's the Cadillac of getting oxygen into your brain. From a functional perspective, things that I think each and every one of us can benefit from, and certainly someone with Parkinson's, is looking at your brain very functionally. The UPDRS, once again, is a great scale to look at specific for Parkinson's. But we need to look at our motor skills. We need to look at our sensory input. Many people that have Parkinson's, as we know, are in the smarter decades of their life. Hence, they've had a little more wear and tear on their body. Hence, you can almost guarantee they probably have some cervical degeneration, and hence they probably have some stenosis. And so the question is, how much of their balance issue is coming from the Parkinson's? How much is coming from cervical stenosis, where they're encroaching around their spinal canal and not getting enough input? It certainly is nice to know, because if they have a large component coming from here, there's things that can be done to increase stimulation along those pathways and have a greater clinical outcome for that individual. We want to look at balance. We want to look at limit of stability, center of pressure. These are all things that we're going to talk about briefly. All of this can be tested with computerized posturography. When you look at the individual with Parkinson that has failed posture, this is not because of weak muscles. This is because an altered perception of where their center of gravity is. They think they're falling back, so they in turn lean forward. If you straighten them out to a neutral position, they think they're falling back, and they're going to compensate for that. We could test this. We could test exactly where their limit of stability is, and you could change their perception of where they need to be. We want to look very specifically at eye function. The eyes are a window to the soul, as you know, and this window can be tested very, very accurately and objectively to give us indication of how various relays in the brain are doing. We could test all different aspects of the eyes, from smoothly pursuing something to quick eye movements called saccades, to what we call optokinetic stimuli, where stripes are passing in front of people. Quite often people say, well, what does that mean to me on a daily basis? You all know people that can't tolerate driving on the freeway anymore. because of the optokinetic stimuli of cars passing by. You probably know people that can't tolerate the flickering of the lights because of this input, or can't tolerate ceiling fans. The majority of our brain output is to take in information, or majority of our brain function is to take in the sensory environment and dampen or suppress unwanted stimuli. If we start to decrease function here, we commonly lose the ability to dampen a lot of this optokinetic input, and it starts to get people dizzy. They have the illusion of movement. They may get sick to their stomach, and on from there. We want to test all these things objectively. We want to test people's auditory processing. The reason why a lot of people cannot understand speech or hearing well is not just because their ear is no longer working, is because their auditory processing, or what we call their temporal processing, in their brain is starting to slow down. You've been to plenty of parties where people are looking at your mouth, right? And it has nothing to do with the level of your voice or the environment. It's that they're having trouble processing sound. Can be tested objectively, and there's things that can be done for that. Visual processing also. It's not just what your eyes see, it's what your brain perceives, and the speed at which you can do that. When we look at somebody from a professional athlete, they generally have these superior abilities. They could see balls coming, they could see plays moving, whereas the other individual didn't even see it was happening. And certainly when we see Parkinson's, we see that wind down. And also, we want to look at reaction times, from your hand-eye coordination to your speed to just your response time, and also memory.
Do these correlate with brain scans like MRI scans?
Absolutely not. Absolutely not. Looking at an MRI scan is extremely important, but it's like looking at the outside of a car. A lot of beautiful cars that don't run well. There's a lot of junky-looking cars that run just fine. And so you need to look at the actual window of function. And this is why it's so important to take a look at these things, because to date there are a lot of scans. Functional MRI certainly is a different story, but there are a lot of diagnostic tests that just look at scans to make sure there's not a tumor, that looks at metabolism. You know, two people may have the same metabolism, but their bodies look totally different because of their machinery. So, as we look at computerized dynamic posturography, we're simply putting somebody on a balanced platform, and this is extremely important in our later decades in life because it gives us a fall risk assessment. We could put somebody on a balanced platform, have them stand with their eyes open, their eyes closed, their head rotated on a perturbed surface, on a hard surface, these are called force plates, and get a very accurate assessment of their risk for falling. It'll actually grade what their stability level is, and more importantly, we can look at what's called their limit of stability, how far one can move before they fall. Obviously, we would expect an athlete to be able to move much further than somebody that's having some neurodegeneration. What is the difference between somebody getting hit and stumbling and recovering versus somebody getting hit and falling over and breaking their head and fracturing their skull and breaking their hip? It's simply their reaction. When you close your eyes and you sway, you're robbing your brain of visual input, so you're dependent on your vestibular input, you're dependent on input from your joints and muscles. All of that is integrating in the part of the brain called the cerebellum, which very intimately fires through the midbrain, which is what's implicated in Parkinson's disease. And if you have decreased integration in that area, because of something primarily wrong in that area, if you have decreased input from joints and muscles that are degenerated and not moving well, if you have changes in your vestibular system, nonetheless, if you have decreased integration in that area, you're going to sway. One individual sways, they get enough feedback from the muscles, the ligaments being stretched from the change of position that they're able to correct. The other person reacts too slowly and they go over. That could be changed. It can be changed very easily and aggressively and effectively if you know it's there. So, this guy doesn't have a cortex like we do to know how to balance, doesn't know which muscles to contract. It's simply a center of gravity. And to say balance is the center of gravity must be above the support, if you look at that statement, it's profound when you look at someone with Parkinson's, because where is their center of gravity? Where's their support? Here. So, Once again, it's their perception of where center is. Here is a simple picture of what a computerized dynamic posturography looks like. Here is a test, that shows one sway. This is a very good individual here. It shows, however, that their stability score is not so good. Red should not be there. These are taken on norms. They're taken against people's age norms. So we're not comparing a 20-year-old to a 70 or 80-year-old. You're compared to someone your age. This will tell us exactly what your sway pattern is. And more importantly, this tells us what your limit of stability is. Here is your theoretical limit of stability, how far you should be able to move. This individual is stuck in this pattern right here. That means if they move into this direction, they're going to fall over. Extremely important when you rehab somebody. So hopefully you're getting the point here. I didn't mention it, but when we talk about neurologic rehab, we're not talking about going to the gym and building your muscles. It's extremely important. We're not talking about doing yoga or Pilates. Those are all great, and we could probably all benefit from doing that more. What we're talking about is very specific neurologic rehab for the individual. So with this individual here, their loss of stability score is 23%. Sorry, not my pointer. I'm borrowing Dr. Blake's. So in this regard, with all of these things that I'm showing you, there is a therapeutic application for this. We could simply use this exact same program and set up targets on the screen in this individual's failure of their limit of stability, and they would literally have to move their body to various targets to reintegrate and retrain their brain how to move their body and what correct motion is. The studies are coming out on this here. These are very new studies. This one here is 2015, this one's 09, but looking at the effects of galvanic stimulation in people with balance placed on either the mastoid right back here that stimulates the inner ear. We do a lot with electric stimulation on the neck or on the feet, depending on the individual, or on one wrist or another while they're on these balance platforms and they can move to certain targets. Now, many people say, well, how about a wobble board? A wobble board, unfortunately, the research has shown that it does not significantly increase your balance. Because if you look at most of these things, people doing something incorrect over and over doesn't make you better at it. Practice doesn't make perfect. I know it's alarming that we all find out now. Perfect practice makes perfect. So you have to do the task correctly. If you're on a wobble board and your limit of stability is poor and you're just bouncing around, you're just reinforcing your poor limit of stability. Does that make sense? So if we move on from there, there's other technology called video nystagmography. Video just simply meaning video, nystagmography referring to the eyes. These are infrared cameras that one can put on, and they very specifically track eye movements. There's a variety of different tests that can be done to look at this. It's very objective. All of the various tests give us an indication of specific relays in the brain. This here simply is looking at what we call a smooth pursuit. This is a very good one here. This shows us what normal is. It shows us what the gain is and what the symmetry of eye movements are. It is alarming how many people have very poor smooth pursuits. And when you look at people's ability or inability to read, it requires a very smooth pursuit. Many people have what are called psychotic, not psychotic, psychotic. Well, many people have psychotic, but for this purpose, we'll leave that to the psychiatrist here. Psychotic intrusions. And it is extremely common as we start to see decreased brain function. Our eyes should be able to smoothly track things in the environment. And when we have a decrease in that function, what ends up happening is we can't track smoothly anymore, so we get quick eye movements jumping in. Every single time you get a quick eye movement like that, which is objectified, verified very easily, it temporarily shuts down the relays in your brain telling you where you are in space. Otherwise, you can imagine if you have 1,000 of these in an hour what your body would feel like. The world would be constantly moving. Extremely important because people that have that tend to start moving slower. You start to move slower, it's called bradykinesia. You start to develop less movement, or you start to move slower, you provide less stimulation to your brain, and you could see how these things can cause a continuous wind down within the brain. We can test quick eye movements called the saccades. This looks very specifically at the velocity of the movements, the accuracy of the movements, and the latency, which is the time to initiate the movements. For instance, something pops up on the screen, how long it takes you to react is measured within milliseconds. We know what the milliseconds should be for a healthy brain. We also know what ends up happening with Parkinson's and other neurodegenerative disorders. One thing I've enjoyed doing, unfortunately, when people go under general anesthesia, because our phlebotomist in our office is an anesthesiologist from overseas, is checking these latencies pre and post surgery. Guess what? We commonly see them go up post general anesthesia. And having that conversation with an anesthesiologist can be fun. So if we look at these things accurately, they give us a good representation of the front part of the brain. This is another test here called the optokinetic stimuli, which is the stripes that we're telling you. This individual is not having too good of a time here. They're scoring about 55% down to 45% in regards to their optokinetic stimuli. That means they're catching about half of the movement that's coming in the environment, which means they're not going to be able to tolerate too much. Not the person you want to be driving next to, not the person that you want to be driving on the freeway with, and it's also the person that's probably not going to be moving too quickly in the environment, because even me turning like this is causing an optokinetic stimuli. If I do this and my brain's working well, I suppress it. If, in the respect of time here, I didn't bring videos, but I would love to show you what happens when you put the goggles on with an optokinetic stimuli, because when you black out the vision, you could see the eyes literally move about this fast when you spin people. The speed of the movement is important, the direction of the movement, and the control of that is important. Next, we look at saccadometry, another objective tool that could very accurately assess the saccades, as I mentioned before, which are the front part of the brain. Now, the reason why this is so important when we look at Parkinson's disease, it's well researched with Parkinson's disease, extremely well researched with neurodegenerative disorders, is that this tells us a saccade to the left very specifically tells us how this right brain is doing. A saccade to the right tells us very specifically how the left brain is doing. What time did you say we have to be out of here?
Quarter of.
10
No,
to.
we have to get out at 10. So.
10 to. Yeah,
Okay.
we have to be out like
I'm moving.
Keep going.
So we can very specifically test the individual hemispheres of the brain. And we know that certain functions reside more on one side than another. It's extremely rare that we see someone with Parkinson's just wind down bilaterally at the same time. It usually doesn't happen. Most people in here, some people in here have Parkinson's. If you're not comfortable saying, does anybody remember a tremor starting on one side more than another? I'll take it as a yes, because we see it all the time. Usually happens on one side, and the beauty of that is in identifying such, you could address these things. Extremely important here. Parkinson's is about a 30-year illness. You've heard Dr. Blake say it. Most of us are fortunate that we may not live long enough to develop it. Some of us are fortunate that we're going to live long enough that neurodegenerative disorders are going to be our new mainstay of this generation because we're living longer and longer and longer. It's about a 30-year illness, and the question is, do you want to wait until you're clinically manifesting the illness? I think most people in this group are like-minded, and you're very forward-thinking, and you realize by the time you're diagnosed with an end-stage disease, there's a lot that can be still done, but it means that something's been happening in your body for a long time, so doing neuroprotective things is extremely important. And in my opinion, having these things looked at an early stage, so you see when you start to develop a little decline, is extremely important, because there's things that can be done to increase stimulation. We see a change in all these functions following car accidents, following head injuries. I deal a lot with many ball players, and it's not a matter of if they've had a concussion, it's how many hundreds they've had. And you could see right after these functions, or right after these traumas, a decline in function. All too often in conventional medicine, they say, well, the symptoms may last a couple of weeks, a couple of months, or on from there. Sure, the symptoms may go away, but have you done anything to look at their function and restore their function? And that is key, because if you start to develop a little decline in function over and over and over the decades, we know where most of us are going to end up, and it's nice to try to avoid that. This is a simple tool called the sacudometer. This shows the difference between the velocity from the left hemisphere, which is represented in green, to the right hemisphere. This person clearly has a deficit in the velocity generators on the one side. Nice thing is, when we know that, then we could give them very specific exercises to target the one area. These are things that you could do on your own at home. These are things that we could do very effectively in the clinic, because we have some tools that allow that to happen. Beauty about this is this test takes about 4 minutes. So we could very simply assess you, put you in the room, have you work some exercises with your brain for 15, 20 minutes, half an hour. We have some people come from all around the world. Some people are from out of town, out of state, and they'll literally spend the day there, and they'll do intense rehab, take a break, intense rehab, and take a break, and we could keep checking and see if we're on track, if they're improving, if they're changing. They should not stay the same. If we're doing a good job, they should not stay the same, bottom line. If we took any one of us in this room and put us through a very in-depth physical assessment of just strength and agility and coordination, and you did exactly what your trainer wanted you to do, and actually went to the gym 3 times a week or whatever it may be, and did exactly what they wanted you to do, how many people would improve on some level within a couple weeks? Everybody would. Everybody would. Because if you're working your area of weakness, it has to improve, unless you had some disease that doesn't allow any changes there. Now, interestingly, with Parkinson's disease, we know that you're losing function, but there still is a lot of function there for many people. And what we want to do is increase stimulation and evoke some plasticity. Is that a term everybody understands? You stimulate these neurons over and over again, and what you do is you actually cause growth of the neurons. They literally start to grow, and one nerve can develop what we call collaterals and have a much greater effect than the 10 neurons that died next to it. So if we're constantly doing things to evoke some plasticity, the race is we want to be evoking enough plasticity so that we're not experiencing too much of a deficit with the ongoing decline. We're very honest with people. We're not going to reverse Parkinson's. We could certainly greatly improve people's quality of life. We see some people that were able to significantly slow down any generation or stop it. We see people whose balance and coordination significantly improves, where they can continue to go out and enjoy their lives with their physical activity. And we see some people that we slow it down a bit, but that bit is works in their favor time-wise. Here are some articles also of recent years. Sorry, you can't read this well. This says saccadic latency in Parkinson's disease correlates with executive function and brain atrophy. Very important. It correlates, saccades, the quick eye movements, correlates with executive function and brain atrophy, but not motor severity. What's everybody looking at? You see somebody shuffling along, you think their Parkinson's is worse. Their motor system is being greater affected, but it may not represent what's happening actually in other aspects. Here, this one here talks about perceptual errors increase with movement duration and may contribute to hypokinesia in Parkinson's. These are the perceptual errors I was telling you about. The perceptual errors, I'm sorry, where the brain thinks it's doing something, it's not doing it. The person may think they're speaking very loudly, but their voice is very soft. They may think that their hand is writing clear, but it starts to decrease in movement and movement and movement. They're not getting the appropriate feedback from their limb up to their brain to actually control that pattern. And a lot of times you could do some very specific tracing exercises with people just to have them retrain their brain in that aspect and get those areas more efficient. A very, very useful tool in not only assessment, but in the rehabilitation is what we call a visual motor integrator. This here, just to give you a little snapshot here, we have some large screens which we could program in a variety of different ways where we could test. We start out testing everybody's reaction time. Doesn't make a difference if it's someone with Parkinson's disease or if it's a professional athlete, we'll test their reaction time. They have to hit targets as quickly as they can, and it literally will measure them to the millisecond. Say they'll be, their reaction time will be 1.06. Very important, because we tell people, you're probably never going to be the same. Now we want to have you rehab at a much quicker reaction time. I had a professional ball player in the other day following an injury, and we literally changed the reaction time by 1 millisecond. 1/10 of a second, not millisecond, 1/10 of a second. And he broke down completely. Couldn't do much. Most of us say 1/10 of a second, you know, what is that? You deal with a professional athlete or you deal with a swimmer or an Olympian, and it's a difference between standing on the podium with a gold or shedding your tears, okay? Knowing that you're not going to be back up there in 4 years. So we could accurately assess one's reaction time, we could assess their hand speed, and we utilize these things because once we have done a very comprehensive assessment, then we could program these screens very specifically for an individual. If we look at this one here, this is just a sampling of some of the stuff we could do. The person's seeing this right image here, and we're making them do a horizontal and a 90-degree flip. So they actually have to perceive what the 3D object is doing. Very challenging. You guys may have heard of people with brain injuries doing brain puzzles and things of that nature. Very important. A lot of these things, looking at objects from different perspectives, have a great effect in what we call the right parietal lobe. The right parietal lobe is the part of the brain that looks at things from different perspectives. So we could program this with time, meaning they have to remember what the object is. We could program in different field of space. This little kid here is autistic, and we could make it so that he has to hit certain targets while they rotate. The rotation over to the right, and he's tracing it with his eyes, is stimulating his right brain because he's pursuing these objects. We're making him tap it with his left hand, which is providing more stimulation up here, while he's standing on a balance platform. And if he doesn't balance and he falls out of kilter, excuse me, it will beep. It'll beep and it'll give him some reminder, and he'll have to correct with the feedback. This next here deals with a bunch of letters on the screen. We can have people go in reverse order of the letters. We can program the letters in one field of space or another, depending where one's weakness is. And they will have to tap to these letters in a certain reaction time, otherwise the letters disappear. It's limitless what can be done. But the most important thing to understand is this stuff needs to be done specifically for one's area of weakness. If we can start to refine all of medicine, as you know, to the individual, you guys talked about methylation before. There's a lab called Boston Heart. Are you familiar with it? Do you guys have it over in Hawaii? They look at the MTHFR gene. That's the methylene tetrahydrofolate reductase gene. Worth doing. It's a great lab. You could get that test done almost at any lab now. But these guys are running a promo that if you have a PPO, they do not balance bill you, which we'll let them handle that. But it's great for looking at your ability to methylate along with various other genes. The key is the customization of medicine. I think that's the next wave of the future, right? Looking at your genomics, identifying what genomics you have, and specifically having your diet, specifically having your medicine cater to that, and certainly your rehabilitation. Interactive metronome, anybody heard of this? It's a patented program that is used for a variety of different things. There's sensors put on the body. You could go through a series of different movements. It picks up to the millisecond if you're right on the beat, hyperactive behind the beat. It is a great program. We don't use it as just as the company directs. We use it very specific to people's individual areas of weakness, and it helps to improve the internal clock, or what we call the temporal processing issue. We all have a little rhythm. Back part of our brain called the cerebellum is constantly receiving input from the environment and constantly firing our brain, keeping things firing at a nice steady rate so that when we need a reaction, we react very quickly.
Is something blocking the side of that?
My water bottle. Sorry. It's getting heated up too, that's why I haven't been drinking too much of it. I've been talking since 6 o'clock this morning. So this is something else called the Spine Force. Great machine. This has a motorized platform. We can control the spin on this platform. It literally moves in a undulating fashion, and then one goes through a series of exercises up here, and it picks up very specifically if there's a bullseye you should achieve, and it picks up if you're contracting on one side more than another. And unfortunately, what a lot of people, especially with Parkinson's, don't have very good awareness of what they're doing with their muscles. The people that I've seen do the best on this have been people from Blue Angels, go figure, they better, to I've had a surgeon in my office, did great. Seen a lot of people in physical medicine do excellent on this, chiropractors, physical therapists, because of the coordination with both sides of the body. And certainly people that have a lot of challenges can be anybody from an athlete that's used to using large muscles to someone like Parkinson's that can't recruit the muscles evenly. 28 peer-reviewed articles that show that this machine fires the intrinsic muscles, the small muscles of the spine, which are very, very, very difficult to activate. Why is that so important? Because when you fire those muscles, you're going to in turn provide a great deal of stimulation right back up to the brain. And when you look at something as simple as back pain and people injuring themselves, they're usually injuring themselves because when they go to lift something, those small muscles are failing, or they're not reacting as quickly as they need to provide stability. And this gives people a better awareness on what needs to happen with that. So, from a perspective at home on what you could do, certainly people with tremors, it's just that part of the brain that's winding down. You could do anything from, have you seen they've changed the name so many times, called Dynaflex? Have you seen these balls? They're little gyro stims. Every sporting goods store has them. They're about $15, $20. Great, great, great tool. It's a gyro stim that you have to move and keep the rhythm with. Very good. They sell them for arm strength. Has little to do with arm strength, has mostly to do with brain function. You could do everything from tracing letters that you don't know, from complex movements. I'd suggest people, not get lazy and eat with the other hand, brush their teeth with the other hand, try to floss with the other hand, doing all these different things to really challenge your brain, because that is what's going to keep things active. Playing music, it's never too late. Never too late. For the young people out there, if you want to know what it's like to have Parkinson's, try playing music. In the first couple years of you learning how to play, you're going to see, unfortunately, what it's like when your hand doesn't do what it wants to. For those that have Parkinson's, if you continue to fire those pathways, they will improve. Anybody can learn how to play music. It may be more challenging. And it's certainly, I think, one of the most underutilized things when it comes to Parkinson's, because there's a rhythm component that stimulates the basal ganglia. All of us dance better I don't do too well one way or another, but most of us dance better with music because it fires the basal ganglia and helps to coordinate coordinative actions. So, thank you very much for your attention. I'm available, we're 1 minute over, I'm sorry, for any questions. Certainly there's plenty of resources that are out there that all of you should incorporate, and I want to empower those that have Parkinson's. It is not a disease like Dr. Blake so well stated. It's one of the diseases you want if you're going to get a neurodegenerative disease, because there's a lot that can be done for it. And certainly the last thing you want to do is let your body wind down and think that you cannot empower yourself to actually push forward. Generalized exercise is great, but there's also many, many more specific things that you can do to make a much different clinical outcome.
Let's try and squeeze in 1 or 2 questions real quick. Anybody have any questions?
Thank you for your speech. What about TMS in the treatment of Parkinson's disease?
The studies are coming out with that, and
So TMS is transcranial
yes,
magnetic stimulation.
There's plenty of studies coming out on that. There is a variety of different ways to stimulate the brain. Many of the better studies right now are looking at pontine or tongue or vagal stimulation. There's a lot of studies looking at the concern that most of this stuff can be starting in the gut. The question is, have you seen the recent article with the Prevotella? They're looking at the bacteria in the gut. I actually have it here where they're looking at the change in the bacteria in the gut is dictating a lot, and they're not sure if it's because it's the change in the absorption of the vitamins or if it's actually a sign of decreased function. One thing that you commonly see with Parkinson's is people start to develop shoulder stiffness and decreased movement in the shoulder and decreased function in their gut early on. And if you look at most people with Parkinson's, they generally have that. So the better stimulation out there is the vagal stimulators, some of the galvanic stimulation, some of the other premodulated stimulation. That's not to say that transcranial does not work.
What do you see in a person going from a sitting to a standing position?
So that's called the sit-to-stand test. Extremely important to test. One of the things you have to be very careful of with people with Parkinson's is whenever you decrease brain function, the majority of brain output is to inhibit muscles. So when someone has a stroke or they have rigidity, it's not because their brain's telling the muscle to contract. It's that their brain that inhibits muscles is not working. Okay? The other function is to regulate cardiovascular tone. So one thing that we need to be very careful with Parkinson's is you start to decrease cardiovascular tone, and when you go from a sit to stand position, not only do you have altered proprioception, but you can have altered cardiovascular tone. You can develop something similar called POTS disease, postural orthostatic tachycardia syndrome, and you decrease blood flow to the brain and you can fall right over. So what do we see with that? We can change that greatly. It's beautiful to see that, you know, we always tell people, you start doing this rehab and you're consistent with this stuff, you're going to forget your cane behind, you're going to forget your walker behind, and you're going to forget to hold on. And, you know, if people are diligent with this stuff, you almost always we'll see a change.
Okay, we can continue some questions afterwards. Let's thank Dr. Azzolino and Dr. Blake for coming. Our next meeting, we're here every third Thursday of the month, so we hope you'll join us once again.